short. Really appreciate having some time for a dialogue here on a couple of areas around our continued evolution and thoughts on how we're going to implement these new benefits that Oregon got in its 1115 waiver. Talk a little bit about some capacity building funds that are going to be flowing out through CCOs, and just to get folks ready and thinking about and some timeframes related there. And I just want to, we'll get to a section on provider qualifications in this discussion today. That's a really key, important piece. And we'll spend a little time there, hopefully get some good questions of what we are going to be expecting for signing up. And as we had talked about before, not have all of the same sort of Medicaid provider provisions, but there still are a few administrative things that we'll talk about and that we're working on. And just want to be super honest of, there of course is a little bit of administrative stuff, and hopefully it will not be too onerous, and our goal is to make it as simple as it can be. So I just want to highlight a couple of areas and go from there. Rachel, who am I handing this to? Am I handing this to Steph?
Yeah, let's just dive right on in. So Steph and Andrea, if you want to introduce yourselves.
Sure, I'll let Director Bell go first.
Great. Well, afternoon, everybody. Andrea Bell, she, her pronouns, Executive Director at Oregon Housing and Community Services. Let me just start by saying it is the end of December, probably at the end of a very long year. And so the fact that you guys chose to spend a little bit of time with us means a lot. We very much appreciate it. Just to maybe just lay out in some additional framework and anticipation for this conversation, as part of what Dave mentioned, we have held a number of engagements, and there will be a number of forthcoming engagements. And so as you sort of look across the virtual screen and we dive into conversation today, one, our hope is that we're creating a space where people can interact and ask questions, and also know that much of what you will hear and what we will forecast today for future engagement is really focused on a few things. One, you all have provided, across coordinated care organizations, housing authorities, service providers, local governments have provided us an array of areas of specific feedback around what you need and what you expect from us in order for this benefit to not only be successful by sort of our collective measures here, but for the people in your community, that we want to see progress that people can see and feel in their daily lives. And so we've taken all of that feedback and put that into a place of engagement that is reflective of all of that, and really reflective on making sure that we are doing our part to support readiness from yours terms as well. And so I would just put that out there as a place of anticipation for today's conversation. And our hope is that you see and feel reflected back in that foresight of engagement, and just know that we're so appreciative of you making the time to be here in anticipation for what's to come with the implementation of this. So appreciate everybody's time. Thanks for being here today.
Steph, you are on mute.
Got it. Thank you. Teams now at least lets us know, or Zoom lets us know. My name is Steph Jerem. I use she, her pronouns. I'm with the Oregon Health Authority, and I am currently the 1115 Medicaid Waiver Policy Director. Rachel, we got slides ready?
Yeah.
Awesome. Love that. Thank you. Okay, great. So I'm going to go through, I think you can feel free to put questions in the chat as you want. We have lots of people ready to answer it. If there's anything that you want more clarification on, we're definitely going to leave room for questions and look forward to discussion. So our agenda today is just a brief background on the waiver. I know many of you have seen this before, and certainly in our first round, but we just want to make sure everybody has the same grounding. We're going to go a little bit more in depth into these health-related social needs services, the HRSN services as we call them. We are then going to talk about community capacity building funds. So these are infrastructure dollars that are different from those service dollars. And then we'll leave plenty of room for questions and what's to come in 2024. So if we go to the next slide, and then the next one, thank you. Overall, if you're not super familiar with what this waiver is in the first place, every state has its own Medicaid plan. Medicaid provides healthcare coverage to folks who are low income based on a standard set of rules that the federal government creates. In Oregon, this is the Oregon Health Plan, or OHP. If a state says, hey, we want to try something different, we want to deliver services in a different way, we can ask the federal government for permission to change those rules. And so that's called a waiver. In this case, this is the 1115 waiver. It's about a specific set of rules. This waiver helps us test and implement new ideas. We have to renew them every 5 years. We renewed in 2022, and so this is a 2022 to 2027 waiver. If you go to the next slide, a little bit more of our history. We'll certainly send out all these slides if we haven't already to make sure that folks can look at this in more detail if you're interested. Our first waiver for the Oregon Health Plan was in 1994. The most recent one, as I said, was in 2022. And we have a couple of big changes in this one, really focused on expansion to the number of people who can access the Oregon Health Plan, and then also these health-related social needs. All of this requires approval from the federal government, and some of those pieces are still in ongoing negotiation. Go to the next slide. Our overall goals of this waiver were first and foremost to address and advance health equity. We are planning to do that by creating a more equitable, culturally and linguistically responsive healthcare system. We want to ensure that people can maintain their health coverage. So that was some of the expansion that I spoke about. If you've heard our 0 to 6 continuous eligibility, 0 to 6 years old, and then 2-year eligibility for everyone else. We want to improve health outcomes by addressing people's health-related social needs and then ensure that we're paying for those effectively. And just a note, our Healthier Oregon OHP members also are included in all 1115 waiver benefits. If you go to the next slide, this will talk a little bit about health-related social needs. That's the official term we're using, but you may have also heard of social determinants of health. That's a pretty popular one in this space that you may have connected with. It's really just talking about the social and economic needs that a person may have that influence how they're able to maintain health and well-being. And so these are things outside the doctor's office that we know contribute to somebody's health and well-being. For our waiver, we have focused in partnership with the federal government on housing support. That's why we're all here today. Nutrition support, climate-related support, and outreach and engagement. And I see some chat. I assume someone will stop me if you want to address anything in the chat. Please feel free.
Steph, we got it. Just keep on going.
Great. So these HRSN specific, next slide. HRSN, we're very happy to say, was supported by the federal government with a $1.1 billion investment in the state of Oregon. 119 million of it is specifically set aside for grants to community-based organizations and other local organizations to help build their infrastructure, their capacity, to be able to provide these services to OHP members. 900 million will then be set aside in future years to actually pay for the services in the moment. So it's kind of two pieces of funding. We're going to go through some of those in more detail coming up. Okay, next slide. That's our background on the waiver. I'm now going to jump into actually speaking about what are these services and how does someone access them. So an OHP member someone first must be an OHP member, Oregon Health Plan member. There's lots of ways that somebody can become enrolled. The person then has to be part of a covered population within OHP. We really focused in our waiver on trying to look at those who are in transition. We're going to talk about that in the next slide. Transition across systems, transition across age categories. And then they also have to have a clinical and social risk criteria. We think of it like a funnel of trying to focus on those who are most at risk to try to stabilize them in and across all of our collective systems. And just a note here, one of the things that is important within the waiver is that we have to be specific about where the funding is coming from. And so this can't replace other state and federal funded programs. So that's something that we always are monitoring and aware of and know will be an important part for us to be thinking about. Next slide, further eligibility pieces. I'm realizing I'm also in the dark as it's become our solstice. Who can receive these services? These are these transition populations I spoke about. So individuals who are transitioning across a system. So for example, that second bullet, discharge from residential and acute care mental health or substance use programs. We know that they're leaving a facility, they're re-entering into a community. We really want to support them during that time period. Another example would be someone who's transitioning across an age category. So the bullet around transitioning from Medicaid only to dually eligible for Medicaid and Medicare. Not always, but most often happens for older adults. And you'll see lots of other bullets here that are particularly relevant, including the first one, which are individuals who are houseless or at risk of becoming houseless. These populations have all been approved by CMS, and just again, not all individuals in the Oregon Health Plan will be eligible. So we're really trying to help clarify eligibility in the months to come. The next slide is the second layer down. So first, someone has to be in a transition population, and then if we go to the next slide, they also have to have a clinical risk factor and a social risk factor. And I won't read all these. This is what we've proposed to CMS. We're actually still in negotiation with them about what this looks like and how someone will be determined. In some cases, we're going to look at self-attestation of an individual. And so these are examples where we've seen that there's evidence of that instability or the particular vulnerability related to housing, nutrition, or climate needs for those who are exhibiting these clinical risk factors and a social risk factor. Okay. Our next slide is going to just to remind everybody, we have 4 categories. Next slide, there we go. These are the 4 categories. We're really going to focus today on talking about the housing supports, but there are additionally nutrition supports. I know we've talked extensively about the benefits of connecting nutrition to housing needs. There are also climate supports. This is very specific to individuals who need devices that will support them during climate and weather-related events. So those are things like heaters or air conditioners, and then outreach and engagement for these populations as well. So I'm going to dive a little bit deeper into housing. I'm sure there's lots and lots of questions. Maybe some of them will be answered. These are the specific housing services that we have available in agreement with the federal government that we can provide through Medicaid to the eligible populations. So housing navigation, pre-tenancy, and tenancy sustaining services. We have lots of detail about what is included within that. Happy to answer questions if people have more specificity within this. Medically necessary home accessibility modifications, one-time assistance with transition and moving costs, including security deposits, first month's rent, utility startup cost, inspection or application fee, and basic household goods, rent, temporary housing for up to 6 months, and utility costs for up to 6 months. And so within each of these categories, there are more specificity. What exact utilities, for example, we have proposed which utilities, we've gone back and forth with the federal government, they're working with HUD. As just an example to say that we've been really trying to create a menu of options that would be available to providers to create the best situation for each individual. So this will really, we're not assuming that every single person that would present with needs would just automatically get all of these services. We're saying that you all as providers in this system would be able to have these options available, but based on the best course for the individual and what their needs may be. The next slide will also show that this is still an enormous population. And so what we have decided through our leadership and conversations with the governor's office and many providers is that the initial focus of the waiver will be focused on those who are at risk of houselessness. This is a HUD definition. And again, we have been working to make that into more plain language, make sure it's really clear that who we're serving. Really looking at those who are medically and financially vulnerable and to avoid those from becoming houseless in the first place. And so we have a couple examples here. Rent assistance for people who have trouble making rent due to a job loss, health emergency, unexpected expenses, or other circumstance. You can imagine someone going into the hospital, you know, at that moment that they're going to be in crisis, they're not going to be able to meet rent, they're missing days of work. Or somebody who lives in an affordable housing unit and requires additional support to make rent. So those are people who are in housing that we want to stabilize and help them avoid becoming houseless in the first place. I'm going to pause there for a second. I just know the chat is fast and furious. So is there anything that would benefit from us talking about at this point to clarify? Callie, I'm looking at you. Or do you feel like we're able to answer most of the questions?
I think we can answer most of these. Are coming in fast and furious, which is great. So I think if you'd like to talk a little bit about, well, actually, we'll be getting to the community capacity building funding later. So let's keep going and then see how we do.
Great. I did see that one. The rollout date is for November 1st to be receiving services. So that's who's eligible. That's somewhat about what the services are that they'll get. And now we're going to talk about who is actually providing these services and how are they going to qualify. So if we go to the next slide, we are looking at some housing specific qualifications to become a provider in this whole system. How are we connecting with Medicaid? So the expectations for providers in this space will be that the provider, it could be an organization, it could be city or county in some cases. They understand the standards and procedures of what we've laid out in the 1115 waiver. So there's going to have to be some demonstrated understanding about the services and what the intent is. They'll need to maintain credentials, licensure, or trainings needed. We're still refining some of this, and we'll be able to share in more detail in the next 4 to 6 weeks about what some of this looks like. And we'll also be meeting members' needs for housing services or able to connect members to a service provider or vendor. In some cases, the provider may be the hub or the navigator space as opposed to the one who's directly providing the service. And we will need all types of providers in these cases to be able to support members through the process. The last piece I'll say here, it's fine, you can go to this slide too. I can do it on this slide. one of the expectations is that providers, these organizations, will need to work with either the regional CCO or our state fee-for-service provider to invoice for the services and to be recognized as a service provider. That will require some registration in our system, but it does not require the specifics of being enrolled as a Medicaid provider. So that is a more complex requirement. We are trying to avoid that for most of our housing and nutrition providers to reduce any kind of burden. There may be providers who want to be Medicaid providers and enrolled as Medicaid providers, or may already be, but it won't be a requirement. There will just be a registration requirement and a requirement to be enrolled in MMIS, which is our system for tracking some of the claims. In process, at the bottom is really working through what communication looks like to make sure that there isn't duplication of services. There's lots of talk and discussion across the state and across regions about which systems and software might be best for some of that. In particular, that second bullet is related to referrals and really aiming for a goal around closed loop referrals, so that when we see someone walk in the door, there's a need for them to get services, a referral goes out. We want that initial provider to be able to understand whether or not that referral occurred, if the person received those services. And there are options for subcontracting as well. We know that different providers provide different services. The next slide is around our critical partners in this space. And so really thinking about how we are going to accomplish this waiver, it will not be able to be done without a collective statewide effort of our community-based organizations to be able to partner in this work. Our goal here is to ensure that eligible members are receiving high quality, trauma-informed, culturally and linguistically appropriate services in a timely way. And we know that this is going to be done through our community partners, that you all have the expertise of this work, you're trusted in your communities already, and that in some cases, many of you are already working with your CCOs, and in others, we're going to help build those connections. And so OHA, from our side, the state is requiring the CCO, which is our coordinated care organizations, to meet the standards that we have here around provider qualifications and readiness. And so there will be some readiness assessments. I think we've also been talking about how we can support regions in developing a collective vision for what this work looks like. We know that you're not only working on the waiver. So how does the waiver fit in with the other work being done on the ground and in the region? And how can the waiver support that work? And so next slide, we have some plans around engagement. These sessions are great, but we really want to be able to have more intentional spaces where we can hear from all of you. And so we're going to go through in the next few slides about what's upcoming for these sessions. I will pause and see if Andrea, if you have anything you want to add about the vision here. Good.
Yeah, I appreciate that stuff. I'll add maybe just a couple of really quick things, and I appreciate everybody being so active in the chat here. This will be helpful as we get into this next portion of the conversation. So just to be really clear about where we're pivoting to in anticipation for implementation, these series of engagements, as you will see, will be focused on readiness and implementation. So we've had a lot of conversations to talk about and orient ourselves to the waiver. I'm sure there's some continued work, and we want to make sure we're resourcing folks, and we're getting to a point of implementation here really soon. So we want to sort of dig a little bit deeper and get into a point of readiness, and also make sure that the topics that we have included in here are, one, reflective of the things that you see and deem as prioritized for readiness. So this is a benefit that, one, not only needs to be workable, but it needs to be effective whether you're in Harney County, Central Oregon, whether you're in the metro region, no matter what part of the state that you're in, we want to make sure that this is workable and responsive to the needs of each community. So as we run through what this sort of draft agenda is going to look like for that implementation, we'd love and appreciate some feedback to see if these specific topics meet your needs and expectation in terms of readiness, knowing your community, the needs in your community, what's already working in your community, and where this effort can be better aligned with that, as opposed to just another endeavor that sits outside of that as well. So Steph, I'll pass it to you to get us into the next section.
Great, thank you so much. So we really want to set up these focus sessions to be able to answer the questions, make sure that there's shared vision in this space. So January, there will be a session focused on developing common language, identifying the characteristics of the impacted population, and developing out the member journey. And we say member journey, that really means from the time that they enter to the time that they're receiving these services. We've heard some of the terminology around a recovery trajectory for some people. That's really what we want to look at in January. In March, we would go in depth on discussing what being an HRSN provider entails. So really diving in to understand the experience of our providers, what are they all expecting, and the relationships with CCOs, for example. We go to the next slide. April, we would have a targeted session related to the framework for statewide implementation, making sure that we all have the same understanding of desired outcomes, understanding what regionally based relationships look like in the state, and reviewing readiness. So starting to get into some of that. June would lay the groundwork for regional coordination and a go live plan. Again, this is for a November launch. Really making sure that we have grown, that people are in the same mindset, that establishment of those relationships and ongoing readiness review. And then in August, we would support the final stages of the go live planning. And so all the things that have been coming in terms of questions, I think as an example, what we would be doing is sorting that out and making sure, is there space within these 5 targeted sessions for us to be discussing this in more depth? How can we bring information to all of you that would connect the dots to the work plan? And in a lot of cases, we may need to reach out to all of you to get more of your expertise in these areas as well. Okay, so I'm going to move now to the community capacity building funds. So we've talked up till now really around the services themselves, eligibility for the services, who's providing the services. Now we're going to talk about how we're actually going to get ready and how can we fund some of that readiness planning. So these community capacity building funds, also CCBF, they were previously known as infrastructure funds or infrastructure grants. You may have heard of all those terms. Oregon has been authorized to spend up to $119 million on this. The goal here is to support development and implementation of HRSN launch in our state. The dollars will go through the CCOs as a pass-through and will be administered to the eligible community partners, which we'll get to in a couple of slides. We're really aware, trying as much as possible to understand the impact that a grant program like this can have on an organization. We want to be aware of administrative burden. And so we are really pushing to have standardized applications, standardized budget request templates so that OHA or anyone is really working with the same language, working through the same templates. And our partners that we'll get to in just a few slides will all be able to apply for and use those funds for the use of HRSN. Okay. So the next slide talks about some of the overarching goals for the capacity building funds. These are goals that have come from conversations we've had with folks on the ground to inform this. We've had lots of community meetings. This has also come from leadership level at our state agencies and from the governor's office. So first is to prioritize these funds for the actual HRSN providers. That's been super clear. We want these dollars in the hands of the organizations who are going to provide these services. There will be a set aside for tribal governments and tribal-based providers. We will also, our intent here is to engage community partners in designing this. That's something that we've been consistent on through the design stage. And really want to promote access to these funds amongst providers who haven't been engaged in our Medicaid billing provider system before. Really trying to build our networks and our relationships across the state for those who are serving the same people. As an agency and as a state, we believe it's our responsibility to support oversight of this program and to ensure that funds are spread across the state. We don't want to see all of this ending up in one region, for example. We really want to see a distribution and a spread. We know that in rural areas, there's a need to really build up services and supports, and the needs may be different based on the experience of those regions. As I said, we're aiming to design a simple and user-friendly application, and we want to promote access to the funds for providers who serve the populations that are those key priority populations, and priority populations as determined by the state. So if you go to the next slide, you will see the actual organizations that we anticipate will likely or could apply. All of these organizations are ones that we know have had some connection in either case navigation or actually providing the services we're talking about, case management, serving as an entry door, outreach and engagement. All of those things will be part of HRSN. And so we anticipate lots of broad distribution of these funds. And the next slide goes into the actual allowable uses. So these have been determined in partnership with the federal government. There's 4 categories. The first is in technology. So this might be something like modifying an existing technology system, purchasing a new billing system, screening system, data platforms. That's all within technology. The next category is in development of business practices or operational practices. So this could be something like designing a new workflow, development of billing or data sharing. Maybe you need a contractor to support that type of work. The third category is workforce development. So this could be things like money for staff that will have a direct role in that, necessary certifications or trainings in the program, support for recruitment. And then the final category is in outreach, education, and convening. So maybe you're launching a new learning collaborative, maybe you're helping bring together other providers of the same services. Maybe you need to do some planning for events or some printing. All of that is allowable uses of CCBF. Will be much, much clearer in the actual applications. The next slide will show you the actual timeline of distribution. And so the contracts with CCOs are out with the CCOs right now. They will be providing outreach around this in the coming 4 months. Within their regions, and we're going to be trying to connect the dots at a state level as well. We know that we're a resource for many of you, and so really want to help make sure that everybody knows where they can get the information. There's going to be, we are thinking about the first year in 2 batches. Oops. Thank you. We're thinking about the next year in kind of 2 batches because we know that it may just take some providers a little bit longer to get their information in, or there may be more questions. And so we have the first batch in year 1 of applications and budget requests launching in March. That's information coming from the CCO and applications being submitted during that time. CCOs would then review the applications in that 3rd row and provide funding notifications. And then there will be a dispersal of funds in August and in October. So this is all I would say high level, these are our goal dates. Always will say things, especially in this space, we want to see how some of this goes, and certainly will be accommodating any kind of, hiccups that happen sometimes. So, and then the providers will begin using CCBF. I'll also note that we really want this to be an ongoing opportunity. So it shouldn't feel like this is your only opportunity to be in. We want to support that. We want to engage everybody, but in some cases, there may be some providers that wait until year 2, or maybe even year 3, for example. So we're definitely not trying to use up all the funds in year 1. Okay. The next set of questions. I'm actually going to skip to the next slide and then we'll get to Q&A. So just wanted to make sure that folks know about, you can go to the next slide. Ongoing engagement opportunities in 2024. So we do have regularly scheduled engagement with the HRSN providers. If you haven't been connected and you'd like to be, we will make sure that I know that there's a bunch of links in this slide deck and our website. This has really been a space where we've been able to say, hey, here's what we're thinking and what's the feedback here, or this is the timeline. How's that resonate for you? And so would love any of you who aren't participating to engage in that. We have recurring public webinars in English and Spanish monthly that help just get out general information to anyone who's interested, and those are recorded, they're on our website. We have regular monthly opportunities for feedback and discussion with other HRSN partners like our CCOs. There are opportunities for these focus work sessions, which we talked about for housing. We're going to try to build for nutrition as well. There's a bi-weekly newsletter. There's a frequently asked questions document that we continuously update. And then we're developing these provider and member journey maps, which are really meant to help those who are engaging in this work to understand what the vision is collectively, if you're coming in as a provider or if you're coming in as a member. So we talked about this a little bit already, but if you go to the next slide, here are some of the upcoming topics that we'll be discussing in early 2024, not just across housing, but across all of the other benefits and the work generally in the waiver. Okay, and with that, the next slide is really just links to our how to ask questions. You can always send questions to this email address and we will route it to the right people to help answer, or we'll address it in an upcoming webinar. This is our website, and then that's how to subscribe to the regular updates. Okay, so 15 minutes for questions, Q&A, and I'll just say upfront that we really appreciate, again, as Andrea said, I know it's the 21st of December, Thursday afternoon, 4 o'clock. Really appreciate everybody's time and commitment to this work and willingness to engage. It's really exciting, and it's also new and takes a lot to learn what a vision is here. So appreciate everyone coming along this ride with us.
Go ahead and take down the slides.
Trevor, you can actually take down the slides completely. Thank you. You were on it. So if there are questions that haven't been answered in the chat, or if there are.
I mean, there was a couple good ones that we didn't get to around sort of Unite Us and sort of links with HMIS. I don't know if we have like a great answer straight off the cuff on that one, but it's a really good point Steph, correct me if I'm wrong. I mean, so the capacity building dollars that are rolling out through CCOs ending up at, community-based organizations, if there is linkages to some HIE work that happens there, that money would be available for that, correct?
That's correct.
So there are some connection points there, but it does give us some good sort of info back to our health information exchange team just on some of those HMIS connections, and sort of sounds like there's been a lot of starts that didn't get to a finish. So we can definitely follow up. So thanks for that piece.
Yeah, and a couple other just little pieces here that I will share as I'm dropping into this chat and maybe interpreting correctly. But we as a state are really just eager to support each region in accessing the tools that they've decided. So I know many have decided on Unite Us or are currently using Unite Us, and there would be support available for organizations who want to be part of that. CIE is something that the federal government was very much in support of in our waiver, but it's also not a requirement. And so paper invoicing is something that we still anticipate may be a reality for many organizations out of requirement and necessity, or out of choice. So that is built into our system as well. The other thing I'll say, just around sustainability, there is an initial cost that will support, or sorry, the initial grant funds that are really to support some of the launching of this work. But then ideally there is some sustainability built in, purely by the fact that these services are reimbursed services. And so that's really what we're testing here, is to say, for these people that we've determined within OHP who have necessity for housing services, we're going to pay the organizations who are doing the work with OHP members. And that's really how the federal government sees building towards sustainability, is that there's built-in space within these reimbursements to be able to help cover those ongoing costs.
There's definitely a few more in the chat, but let's see if there's anybody that is brave that wants to raise their hand at 4:48 on a Thursday afternoon.
Just
There was
share
one
that. Oh, go ahead.
couple of brave souls.
Go for it, Andy.
Yeah, Andy Miller, Our Just Future here in the Portland region. So I think, and I put it in the chat, I think the challenge for this for existing providers is going to be how to build sustainable staffing patterns to implement these dollars when we're used to annualized contracts that can fund this work. So that's one big challenge is, if you are a Medicaid billing organization or primarily providing Medicaid reimbursed services, you can predict your reimbursements and build staffing patterns based on that. That's going to be much trickier for those of us who may do this work less frequently or aren't doing it now. So that's thing one. I think thing two is those of us who are operating in the homeless space all know, and I know you've received input, that the 6 months of rental assistance is not the end of what most people need. So how this integrates into mainstream programs that we're already delivering will be something we'll need some help developing over time. And I'm particularly interested in, how that coordinates with coordinated access, because you could effectively be reducing people's risk by putting them on rental assistance. But then when it times out, they're suddenly back at risk again. And if there isn't a linked housing placement, that could be really hard. I could see this being really advantageous for residents of affordable housing who maybe are falling behind in rent or have a shorter term need and have a subsidized rent. But affordable housing providers are typically, I don't see a whole lot of my peers in that space on this call. I don't know if they've been at the table. So yeah, just want to, I think this is less of a standalone program and could be more complementary to work we're already doing. but complementary services are really hard to keep funded and stay sustainable. So I just think, some kind of work group or answering those questions about how we really build programs and build budgets in ways that are reliant on this funding source will be really key to having it being successfully implemented.
Andy,
So I
welcome
guess
to our,
that's more of a statement than a question.
yeah, welcome to our fun joint world ahead. I mean, I think Andrea, I feel like this is the daily, weekly, monthly, hourly question that we talk about. I mean, it's the both excitement to have Medicaid in this space and, have opportunities here, but yeah, I like ultimately I think the test, can we do more integration between healthcare and housing than we've been able to do before? And, all the things that, right, like 6 months of rent, of course, we would have loved more. We asked for more, but that was as far as CMS was willing to take out that red line that we never could do this. This is as far as it would go. And this will only be as good as the integration. Andrea, that's the work ahead of us.
Yeah, I think that's right. And Andy, I so appreciate all of your comments and reflections, and I'm believing me, I'm taking copious notes here. I see Kate's hand up, so I'll make my comments really brief so that we can at least get in another 1 or 2 questions here. Andy, nothing that I would categorize as an answer here, but here are a couple of things that, in terms of how I think we have begun to think about this is, I think some of the states that have framed this as, from a housing perspective, as, this is in the Medicaid space, this is considered to be a pilot, right, or a demonstration. But I think for us, that all of us that have been in the space directly or indirectly serving people experiencing housing instability or unsheltered homelessness and all of the various forms of manifestation, know that there really isn't a pilot for housing. People get access to affordable housing, they get the supports they need in the community of their choices. That tends to be a platform for health and wellness. And so we don't need to test that hypothesis. What I've often said is, I think we're not testing that hypothesis. We know that to be true. What we're testing is the infrastructure capacity and the durability to take something as large in scale of this, with regulatory requirements that come with all of the things they do from a federal perspective. And how can we take the girth of that structure, the things we love about it, the things that are less than desirable, and mold this into a way that fits within our existing space? And part of, from my perspective, that is where the testing comes in. Not so much the hypothesis of does housing work, but it is really testing the infrastructure capacity of how do we make this something this large in scale, fit within the existing systems and frames thereof. And I think you're exactly right. This is not, it cannot be separate and apart from the existing work. And so where can we build upon some of the existing things that people are already doing really well in their community? Where can we continue to build upon, healthy homes initiatives and some of these other things that are in place? So I think in many ways, this is about testing the production capacity of our infrastructure. And I think being that we're first out of the block here in Oregon, there's some perhaps pros and cons to that. But I think one of the things that it positions us really strongly to do is to shape how Medicaid thinks about housing, and particularly their proximity to housing, and that there's an inherent responsibility that our Medicaid system, that our Medicaid funders absolutely put resources behind housing because it is necessary, it's the non-negotiable. And so I think that is really what we're beginning to dig into and test, and part of why, candidly, we can't be exempt from feedback as the state, because ultimately you all are the implementers, and we need to support the implementations efforts that are going to take place locally. All right, I'll yield, Steph, and see if we can get to Kate. And Kate, hopefully I didn't take too much of your time here.
Well, and actually you answered my first question, so thank you for sharing your thoughts and vision there. I would also just really encourage OHA to think about ways that the risk of CBOs could be mitigated, especially as they walk this path of Medicaid billing and whatever it's going to look like. And how can additional flexible funds be provided so that if, Medicaid or the state comes back and says that something wasn't allowable, either through the initial billing or auditing, that there are other resources available that they can tap into that can help make sure that they remain stable and able to continue to walk this path. Whether it is state funding, it is foundational funding, or otherwise. That was something that worked very well in Washington State that I would encourage Oregon to continue to take a close look at.
Yeah, I so appreciate that, Kate. I'll just reflect that back up, because I think that is, maybe I'll say what is like the uncomfortable thing, or maybe historically the uncomfortable thing, but I'll just say it. But I think, Kate, what you're expressing there is around risk tolerance, and particularly historically, state government infrastructure tends to have a certain perception of risk tolerance that I think then has a ripple and a effect in community on the peoples that we serve that sometimes is counterintuitive to the very things that we're trying to do. So I appreciate that and lift that up. I think what I'm also teasing out from this is that we were expressly clear within our
Oh, no,
Uh-oh, I think we lost Andrea.
at a very key point.
Well, I would never try to speak for Andrea by any means. Yeah, I mean, I bet I know where she was going, and I mean, I think just for sure, I think ways that we are collectively supporting community-based organizations, and also understanding that getting into the Medicaid space is scary, and how we are supporting that community differently. I mean, while I hope in, sort of how we're going down this path of having providers, so in this case, like a CBO, a housing agency, have to do some administrative work to be registered for MMIS, that should be relatively painless. And hopefully the billing process is a more normal invoicing process that you likely would have done with vendors before. So it's less about the Medicaid coding. It's the things that make Medicaid scary, and frankly, also, like, I think super complicated, that we're trying to leave some of those things at a CCO level, and not have to have a CBO get into a lot of those issues. Just do the work, get paid for the work, keep people housed, and go and be, again, appropriately paid for that work. And I know it's not going to work perfectly on day one. So I think that there's going to be a lot of learning, and we need to have spaces for that learning period between us, the CCOs, and all of us to build from here. All right, Steph, it is 4:59.
Hey, we did it. So thank you all so much. Really appreciate your time. We know that we've engaged with some of you one-to-one, but please reach out, and we will be communicating about those targeted sessions and would love your participation in the coming months. If there are other things that are popping up, or if you have questions about, please feel free to use that email address. We do work closely with the Oregon Housing and Community Services as well. And so if you're already in communication and reaching out to them about any of that, we will make those connections. So thank you all so much, and I hope you have a happy holiday.
Thank you.